Hello, my name is Mark Miller, and I'm the Chief Medical Officer for bioMérieux. Thank you for joining the session today. I will be discussing the role of diagnostic solutions for COVID patients, and we'll try to cover the aspects of diagnostics related to diagnosis of the patients themselves, prognosis, complications, and follow-up. So this is a question that comes often. What are the best tests for SARS-CoV-2 or COVID-19 patients? And as a good epidemiologist, my answer always is, it all depends. And that's true because there is no such thing as the best test. It all depends on the situation and what your goal is. So the questions, really, are you trying to diagnose a suspected COVID-19 patient? Are you looking for the prognosis of a COVID-19 patient, whether to hospitalize or not? Are you looking for secondary infectious and other complications in such patients? Are you talking about the post-COVID period and what could happen there and if there are any follow-up tests to be doing? The other questions that really come to mind when choosing the right test is, do you have a PCR lab set up? Since PCR tests, as we'll see in a little while, are the gold standard. What budget is available, because that drives a lot of the type of testing that can be used. And then there are pre-analytic issues and post-analytic issues. So the pre-analytic issues, for example, is what type of specimen are you looking for? Most tests are now, for diagnosis, are standardized and validated with nasopharyngeal swabs or nasal swabs, but people are asking about saliva. What about other types of specimens? And so you really have to look at this as well. And of course, the post-analytic issues. A lot of what we're seeing today are good testing being done in good labs, and then somehow the results don't get back to the treating physician or the patient in time to make good decisions. So this is all what goes into answering that question about what is the best test for COVID patients. So today what we'll be doing is we'll be covering suspected COVID-19 patients and which diagnostic tests are available and what can be used, and what is the types of performances that you can expect. Diagnostics for prognosticating COVID-19. This is a new disease. We're not sure about the best prognostic factors, whether they're clinical factors or laboratory factors. Secondary infectious complications and acute kidney injury in COVID-19, which is becoming more and more recognized and important, both the secondary infections and the acute kidney injury. And we'll talk about the post-COVID-19 period and if there are diagnostic tests that can help us in that situation as well, such as back to work. So there's two caveats here. The first caveat is this is not an exhaustive overview of the epidemiology and pathophysiology of COVID-19. I am focusing on diagnostics, but it is not a review of the performance of every COVID-19 diagnostic test in the world. All information is subject to change in this presentation. This disease is new. There's a lot that we do not know about this disease. There's a lot that we do know, and it's very similar to other viral infections. And then there are other parts of this disease that are totally different. And so a lot of this is subject to change as we get more information. And much of the information about the performance of diagnostic tests is internal or unpublished documents and some press releases and some regulatory documents. I'm not going to go through all of this, but I warn you that there are various sources of information, traditional and non-traditional, because of the rapidity of the COVID-19 pandemic and the fact that people cannot publish and disseminate their data in the usual ways fast enough. So we rely on other documentation that's around. The second caveat is buyer beware, okay? Performance of many of the diagnostic tests that you will be seeing in the literature and on websites depends on the country in which the patients and the analyses are done. It depends on the healthcare system in which it was done. It depends on a publication bias when you're reading publications. A lot of negative publications don't get printed, and that's true in the COVID pandemic as well. The types of patients, very, very important. Was the testing done on asymptomatic patients, mildly symptomatic patients, critical ICU patients? This makes a big difference. And timing. Timing, you'll see at the end, is extremely important for PCR tests, for antigen tests, for serology. Timing is everything. When is the testing done, or when do you want to do the testing? Are you catching the patient during the first few days of symptoms? Is this already into the clinical syndrome. Do they have no symptoms and they're just coming for a test? And how many days after the diagnosis are you there with the patient? And the specimen type, as we talked about. Are you talking about nasopharyngeal swabs, oral swabs? Not everything performs the same. There are many tests available internationally. There are even more tests that are available, hundreds locally on the local scene, including India, China, for instance, where there are many, many tests available only locally in that country. And there's a lot of heterogeneity among the performances and the validation criteria, so read carefully. I mean, this is not a crash course on how to read publications and memos and internal data, but read carefully in terms of all that I've just told you, the types of patients and the timing especially important. So what I'm not going to do today is, as I said, go through every test and every table that's out there and the performance of these tests. But there are some good data sources if you want to go into the detail on a particular test or types of tests. There's the FIND website, and I've given you the link here, where they list everything by category: manual molecular, automated molecular, antigen tests, serology lateral flow tests, serology automated tests, etc. You've also got the FDA website, where all of the emergency use authorizations are listed by category of test. And again, that's a very easy website to find. And of course, there are review publications that are coming out one after another at a very fast speed. So let's get into the agenda. Suspected COVID-19. You have a patient or somebody's got a patient and they think that they have COVID-19, and what are the diagnostic tests available? Well, essentially, you can go anywhere from just clinical diagnosis based on clinical signs and symptoms all the way down through molecular tests, antigen tests, serology, and radiology. And we're going to quickly go through each of these and what the expected performance is and where they perform best. So a clinical diagnosis of signs and symptoms, the problem is that the signs and symptoms of COVID-19 are not specific. Even lack of smell or loss of taste is not specific to COVID-19 and occurs in other viral infections. And it can be confused with almost any other virus. Outside of the so-called winter months or flu season, the probability of COVID-19 being the cause of symptoms is much higher because there's less viruses circulating, but the probability is still quite low. During flu season or the winter months, when other viruses circulate, the probability of anyone coming in with symptoms being COVID-19 is much lower because of the probability aspect. Therefore, clinical diagnosis is not really a great way, other than unusual circumstances where you've got, for instance, a recent contact of a COVID-19 with compatible symptoms, where your pretest probability is probably quite good and quite high. To show you the point about what happens when other viruses circulate, and we don't know what's going to happen with the upcoming winter season in the Northern Hemisphere when other viruses will be circulating. But if you look at this, this is data that comes from our BioFire trends analysis, epidemiologic analysis, which is free to anybody to view online at that link. And you'll see that I put the snowflakes in the winter months and in the sunshine in the summer months. And even though there are less viruses circulating in the summer, there are still a lot of different respiratory viruses circulating all year round. So you pop somebody in with COVID-19 in the middle of all this with the usual symptoms, and good luck differentiating this just based on clinical signs and symptoms, whether it's COVID-19 or whether it's paraflu or RSV or human metapneumovirus, et cetera, et cetera. What about molecular testing? Well, everybody, 2 years ago, nobody knew what PCR was outside of labs and healthcare systems. Now it seems that everybody knows what a PCR is and what molecular testing is, which is great for the diagnostics industry. It's really pushed us to the forefront and shown the value of these kinds of tests. But PCR testing is obviously able to detect the presence of the SARS-CoV-2 virus. Reliable specimens at the present time are almost exclusively nasopharyngeal swabs, with some tests, the antigen swabs, now doing nasal swabs, and with some few exceptions using saliva. But almost everybody is using nasopharyngeal swabs, and there's lots of videos out there on YouTube and other sites to tell you how to do a proper nasopharyngeal swab without really causing too much discomfort to the patient. The problem with PCR tests, as we all know, and we've known since the inception of PCR, it cannot differentiate a live organism from a dead organism, and that's no different from SARS-CoV-2. You can have live virus, you can have dead virus, and the PCR test could be positive. Results with PCR can vary anywhere from very quickly, 45 minutes to an hour, with, say, our BioFire system and some other systems, to several days if routine PCR is done in batches. And this is part of the problem that many labs are doing batches. They're overwhelmed. You don't get into the batch, therefore you have to wait another day, and then the result takes another day to get through. And a test that normally takes 3-4 hours in a batch, you wind up having a turnaround time of 4 or 5 days or longer because of the pre and post test issues. So the problem with PCR obviously is that you can't detect an infection that occurred 2 weeks ago or 3 weeks ago unless there's virus still present. And for that, we're going to come to serology, obviously. But most of the time, PCR doesn't last very long. Now, this is a very common question. How long does a PCR test for SARS-CoV-2 last in somebody who's symptomatic or asymptomatic? And how long will you get a positive PCR test? And the answer currently is that we don't know. This is a new disease. You know, we don't know this for many of the other existing viruses. We certainly don't know this yet for SARS-CoV-2. So, you know, it's likely several days to a few weeks, but I'm going to show you at the end several cases where people have been positive after their initial symptoms going on 4 months, and obviously picking up just dead virus. They have no symptoms and they're not infectious. Now, obviously, gold standard. PCR has become the gold standard and is still considered the gold standard against which many other tests are compared. Now, what happens if you have a PCR lab or you don't have a PCR lab, but you want to do PCR? Well, if you do have a PCR lab, it's great, but you know, PCR labs are very complex to set up. You need trained personnel, you need separate lab spaces, you need equipment, you know, you need extraction reagents, you need amplification machines, you need detection equipment, and that's, for instance, our Antigen kit, the RT-PCR routine kits for SARS-CoV-2, but you need the setup. Can you have PCR if you don't have a PCR lab? Yes, the answer, of course, is yes. There are tests like our BioFire platform that is able to perform really high complexity PCR tests without a PCR lab at the push of a button. And you will see many systems like this. Obviously, this is the one that's most well known in terms of, and the most placements in the world. But the having the ability to do PCR without a formal PCR lab is now available. What about choosing between a COVID-19 test and a syndromic test? Obviously, as the winter is approaching and there's more viruses circulating, people are going to want to know which virus this patient has, and it's not just a yes/no for COVID-19. But there's still a role for single COVID-19 tests. So when would you choose a single COVID-19 test versus a syndromic test, which gives, you know, for instance, with the BioFire test, gives 22 or 23 different pathogens all at the same time? Well, a single SARS-CoV-2 test or COVID-19 test is probably indicated where you have a high suspicion of COVID-19. For instance, they've been in contact, they're part of an outbreak, they have asymptomatic or mild disease, and you're really not going to do much in terms of hospitalization, and you've got a high volume of patients or tests coming through and you want a high throughput. So for things like that, our Antigen kit, for instance, where you can batch hundreds, you know, anywhere from single tests all the way to hundreds of tests at the same time, those are very useful. On the other hand, syndromic tests are extremely useful when they contain SARS-CoV-2, like our BioFire respiratory panels. When you're looking and you don't know which pathogen is involved, for instance, in the winter months when other viruses are much more likely to be circulating, when you have moderate, severe, or critical disease and you really have to know what the pathogen is because you have to know this for infection control purposes, for bed placement, for treatment options, etc. And so a lot of this is really part of the reason that syndromic is a desired approach here. And of course, the syndromic tests are very fast. Batching is much slower, and you've got such as the BioFire test, 45, 60 minutes, where you can deliver a result very rapidly. And so this is an example of what we deliver with the BioFire respiratory panels. So what about antigen tests? So antigen tests have made a big splash recently because there have been some FDA EUAs that have been given to antigen tests. They're able to detect the presence of the antigens to the virus, usually proteins. Again, reliable specimens right now are nasal or nasopharyngeal swabs. There really isn't any antigen test that's been validated to have a good performance with other specimens. Again, like PCR, you can't differentiate a live from a dead virus. And most are lateral flow EIAs or enzyme immunoassays. And the results, because of that, are pretty quick, between 15 minutes and an hour. Some of them may be a little quicker than 15 minutes. In the USA, FDA has granted 4 EUAs, and it's important to remember that these EUAs, because of their somewhat decreased sensitivity compared to PCR, have only been approved for symptomatic patients. Now, it varies according to the 4 different tests. Some are only for symptomatic patients during the first 7 days of their symptoms. Another one is for the first 5 days of symptoms. Another one is for the 12 days of symptoms. But the important thing to remember is that currently antigen tests perform best when there's symptomatic patients, and it's not for patients who are asymptomatic and just in contact. We're not sure about their performance there. Like PCR, you can't detect an infection that occurred weeks ago unless there's still virus present, and that's not usually the case. So now let's talk about serology. So I'm showing you the example of our VIDAS serology. We have both an IgM and an IgG. Serology or antibody testing, there's a number of companies that have put out serology for SARS-CoV-2. It's able to detect the presence of the antibodies, not the virus, to SARS-CoV-2. Reliable specimens at the present time include whole blood or serum plasma or finger prick blood. And it's important to remember that for most regulatory agencies, finger prick blood is considered to be different than whole blood. And that's because the way you obtain it and the validation that has to be done. It cannot differentiate a recent from a remote infection. If you have positive serology, the infection could have been 4 days ago, 8 days ago, could have been 2 months ago. It cannot differentiate the timing of when the infection occurred. And with some of the tests, the results are available in 15 minutes on lateral flow assays. With our VIDAS assay, it's about 27 or 30 minutes with these single automated tests. And then if you do them in large batches on these big robots, it could take a few hours to, depending on how the results are put out, a day or two to get the results to the people who run the test. And right now, because it's serology and it's detecting antibodies, you cannot tell if anybody is infectious or not based on this test. So the current consensus for serology is that it's good to document a prior SARS-CoV-2 infection. Almost everybody develops IgM, IgG unless they're immunocompromised, and there are cases of people well documented they don't develop IgM or IgG. The lag time is variable, but probably from days to weeks, and I'll show you something soon showing you the typical time frame. And there is individual variability in the antibody development due to host factors. Some people produce antibodies very quickly and briskly. Other people do it slowly and at lower levels. And this seems to be a factor of the severity of the disease as well as on genetic factors of the individual that we are not sure about. In terms of as an aid of a current infection, this is an indirect method. Of course, the direct method of looking for the virus itself is preferred, but there are some places where you either don't have PCR or antigen tests, or the patient was not able to get one of those direct virus tests and now comes to you after the disease is finished, after the symptomatic period, and said, did I have SARS-CoV-2? Did I have COVID-19? And in that sense, serology can be very helpful and complementary to tests that either weren't done or weren't available. And again, here is the caveat. For serology, beware of the timing. Although almost everybody, unless they're immunocompromised, will produce IgM, IgG, it takes time. Now, the classic demonstration of IgM and IgG is as you see on the left side of the slide. But with COVID, it seems to be a little bit different. It looks like that IgM and IgG actually start to rise at the same time. Of course, IgM then starts to drop after several weeks, whereas IgG does not or drops much slower. And because of that, you have to be very, very careful at validation of tests and the timing, the patient type and the timing. The more severe the patient, the higher the titers generally and the faster they produce antibodies. And the less sick the patient is, the slower and the less antibodies are produced quantitatively. And that determines the sensitivity and specificity. So be very careful when looking at serology validation at the patient type and the timing. And often that's left out on the tables. This is a good example of what we've shown with our VIDAS IgG. And you'll see that the time is on the bottom and the titer of antibodies is on the y-axis. And you see that right during the first few days, from the first 4 days of illness, our serology and most serologies are not very sensitive in picking up these patients. But as soon as you start getting 6 days into the illness and after, the serology becomes quite sensitive. And then after about 10 days, the VIDAS serology reaches a 100% sensitivity. And many of these tests, because of the specificity of their target, are very, very specific. So again, look at the timing and the patient type. And again, we've done demonstrations of our serology on hospitalized and non-hospitalized, severe and not severe, and you'll see different patterns. So what about radiology? There was a lot of talk about using radiology in China when they didn't have tests at the beginning and people were doing x-rays quickly to see if patients had COVID. As you know, radiology is not specific. It can't differentiate pathogens. But in the right setting, an epidemic, as occurred in Wuhan, or the contact of a case, it can be useful. Chest x-rays are rapid and inexpensive if you already have the equipment. CT scans can also be relatively quick if you have the equipment and if you have the system that's set up. The performance, however, has only been shown in symptomatic patients. So we don't know what the performance of chest x-rays or CT scans are in contacts who are asymptomatic. The most common patterns are typical viral type patterns, which is ground glass opacities or bilateral patchy shadows. The important thing to remember, and this is striking, and again, this disease seems to be different than other viral illnesses, that a significant proportion of symptomatic patients, including severe patients, and this comes from the China epidemiology, so about 5 to 25% of patients, including the severe patients who wound up in the ICU, had a normal radiology, chest x-ray, and or CT scan at the time they were first seen and diagnosed. So this makes radiology questionable in terms of a reliable test, probably much, much better as you're more severely ill, but even in the real severely ill patients, it can be normal. And this is something that is quite new for COVID-19. Okay, what about diagnostics for prognosticating COVID-19? Well, I wish we had. There's a lot of publications out there. There's publications on protein biomarkers that can predict mortality or severity. One publication came out with 27 protein biomarkers that's able to predict who goes on to ICU admission or death and critical illness. There are classic inflammatory markers that have been shown to be of value, like IL-6 and IL-10 as well, in terms of associating with COVID-19 severity. At the present time, the above findings that I just showed you, along with 2 big reports of improvement in critical patients with corticosteroids, suggest that some of these inflammation-related markers are probably beneficial for prognosis. But which ones and when to do them and how prognostic they are, really we are too early in terms of the evaluation of these to really understand. They're probably useful in some settings, but too early to tell to really endorse using any of them in a particular situation. What about acute kidney injury in COVID-19? Can you prognosticate who will develop acute kidney injury? Well, if you look again at some of the early Chinese epidemiology that came out, you see very high rates of acute kidney injury in some patient populations. Now, why? Some populations had much higher rates. It's not known. Maybe later diagnosis, maybe triage for more severe patients. We're not sure. But there's a variety of incidence rates for AKI, acute kidney injury in COVID-19, but it's not insignificant, and they can be pretty substantial. And it also relates to mortality. So this is again from the Chinese cohort. I believe this is from Wuhan again, and showing that if you do develop AKI during your hospitalization with COVID-19, you are much more likely to die. This being very important, it looks like AKI is a risk factor for mortality in COVID-19. about half of patients who do develop AKI with COVID-19 will die. And so clinicians should really consider interventions to protect kidney function when these patients are first seen. What does that mean? Well, there is a test called the nephrocheck test that's produced by bioMérieux, and the intended use and indications are as an in vitro diagnostic assay to measure two biomarkers in urine, TIMP2 and IGF-BP7, in order to give an AKI risk for an individual patient, a critical patient, and to give them an AKI risk of developing AKI within the next 12 hours. In the USA, the clearance is a little bit different than in Europe, but essentially it's in patients who have acute cardiovascular or respiratory compromise. And one could say that ICU COVID-19 patients are similar to that, and to come up with an AKI risk, which determines the risk of developing AKI in the next 12 hours in adults. In Europe, it's very similar, but a larger indication in terms of risk assessment in the critically ill. So what does this mean? This means that it's a rule-out test. Patients with an AKI risk in a nephrocheck test that comes out as less than 0.3 are very unlikely to develop AKI within the next 12 hours. That's what all the studies showed for registration. But what is known about nephrocheck and COVID-19 patients? Well, there's no data about the performance of nephrocheck in critically ill COVID-19 patients right now, but we are doing several studies in Europe to evaluate nephrocheck in this particular patient population. But it should be able to detect kidney stress because the original studies that looked at the validation of nephrocheck included many different patients in critical ICU care, including trauma, surgery, sepsis, etc. And the expectation is that it would perform the same, although we need to see clinical trials. So what about secondary infections and in COVID-19? Well, co-infections at the time of COVID-19 presentation, when you see a patient and they're ill, the question always is, do they have another infection at the same time as the COVID-19? There was a meta-analysis showing a bacterial co-infection in about 3.5% of all patients of all severities coming in, but of the ones who were severe and eligible for ICU care, it was about 8% that have co-infections. We're talking about pulmonary co-infections at the same time as their COVID-19 during their admission. So this is significant. There have been two good studies using the BioFire pneumonia panel on COVID patients at their arrival in the ICU. The first one in 47 patients in France showed bacterial co-infection with COVID-19 in 28%, using the pneumonia panel, which is a very broad molecular panel, including resistance markers. And most of these infections, these co-infections, were methicillin-sensitive Staph aureus, H. flu, and strep pneumoniae. The second study was done in Belgium in 32 severe COVID-19 patients, also getting a BioFire pneumonia panel at presentation within hours using a bronchoalveolar lavage or an endotracheal aspirate, and finding that they had 41% with co-infections, and leading to an antibiotic modification, which was appropriate in about 47% of those patients. And again, the types of infections that were seen with COVID-19 at presentation were Staph aureus, H. flu, and in this case, Moraxella. What about secondary infections occurring after COVID-19, regular healthcare-associated infections, which we try to avoid, but unfortunately do occur? There's very scant data on secondary bacterial pneumonia in the literature about these patients. A meta-analysis has been done on secondary bacterial pneumonia in these patients, which is about 14% in that one series. In China, it was about 14% of COVID patients in the ICU developed a secondary bacterial pneumonia, consistent with the other meta-analysis. And another study from China showing secondary bacterial pneumonia rates in hospitalized patients that really varied with severity. If about 4% in moderately ill patients who were hospitalized, 8% of severely ill patients who were hospitalized, and 35% of critically ill patients, despite the widespread use of antibiotics in all three groups. So the preliminary evidence is that HAI rates look to be higher in COVID-19 patients than other ICU patients that we normally see. And this is probably multifactorial. It's probably because of challenges in the rapid upscaling of ICUs in the COVID pandemic. reduced staff to patient ratios, unfortunately because of the pandemic, and replacement of staff in the ICUs with those who are unfamiliar with the prevention bundles, increased length of stay and complexity of these patients, and inadequacy of PPEs in the pandemic setting, perhaps. It's really not known, but it seems that there's a higher HAI rate in these patients. And there's also some evidence coming out that these COVID patients have severe immunologic changes when they come in with COVID sepsis that would make them more at risk for HAIs, and I've given you the reference there. The part about antibiotics is important because a lot of these patients get antibiotics right when they're seen and for several days in their hospitalization. This is a review showing about 73% of patients getting antibiotics. These are COVID-19 patients, meaning that antibiotics is the #1 treatment category that these patients receive. That's a problem because does that mean that if these patients then go on to develop healthcare-associated infections or HAIs, they are more likely to develop antibiotic-resistant infections? And that's the big fear. The big fear is that this group of patients, which is very numerous in hospitals and has been and continues to be, will they generate more AMR and antimicrobial resistance concerns in the world? It's been something that was actually remarked on by the WHO, saying that the COVID-19 pandemic and the overuse of antibiotics may ultimately lead to more AMR globally, to be seen, but certainly a worry. Which means that when you're looking at these patients, when they get admitted, you have to consider healthcare-associated infections as a complication. And so the usual microbiology tools, such as all the tools that bioMérieux offers in terms of culture and molecular testing, and mass spectrometry, automated ID and AST, and susceptibility test is extremely important in order to manage these patients once they're admitted to the hospital. And of course, pathogen identification and susceptibility to be able to detect those that have resistant infections and to target the treatment appropriately is really crucial. So what about after the COVID-19 period? These patients have been seen, they've been treated, and is there a role for diagnostics? Well, one of the big questions is there immune protection after the disease? And how long does it last? So there is some preliminary data from sequential blood samples in different cohorts of COVID-19 patients, experiments in non-human models, as well as some ongoing data from the vaccine trials that is coming out. And essentially, it looks like antibodies against receptor binding domain, or RBD, are more likely to neutralize virus in vitro. So that's one aspect. What respective roles do humoral and cellular immunity have? And when we measure antibodies, are we really measuring the person's immunity, or are there many other factors that determine whether that person can get reinfected or not? And it is very likely that there are many other factors besides just antibody levels. And positive serology, now we are starting to see, as with the VIDAS assay and with other companies, have shown some good correlation with neutralizing antibodies, which means, yes, they probably are protective, but it's probably very test dependent. For instance, antibodies that are directed against RBD are suggested to be more neutralizing than those against nucleocapsid. But again, a lot of this data is very preliminary and to be verified. The other thing that I mentioned that is true, and you'll see that in almost all the different serology that comes out, is that asymptomatic and mildly symptomatic patients produce a less brisk antibody response. Does that mean that their protection is less and will go on for not as long a period of time? Will they be less protected? Will the duration be small? We don't know. We don't know an answer to a lot of these really important questions. And we have seen patients who are immunocompromised who do not produce any detectable antibodies at all. Are they eligible to be reinfected again? There have been some cases that have been shown and published to be reinfections, but these are very few and far between. We just don't know the answer to this. And the duration, as I said, is we don't know, but probably antibody levels will confer some long duration, and reinfection is very rare. So positive serology, bottom line, probably is indicative of protection. Duration is unknown. Serology testing to assess protection is currently not recommended by any national professional guidelines because we just don't have enough data upon which public health people are basing their guidelines for a national program right now, even though it looks like they probably are indicative of protection and might be of some help. So what about follow-up PCR tests? Natural history of PCR positivity and correlation with viral shedding in COVID-19 is not known, but it's not known for a lot of other respiratory viruses as well. Many cases of COVID-19 patients of being PCR positive for extended periods of time after the initial positive PCR. Some are explained by being immunocompromised, but there are many others that are not explained. And this is probably just residual viral particles or nucleic acid that's being picked up. I've chosen to show you one case from my native Canada where a woman who is a young nursing student who got an original infection, she worked in a long-term care facility and was positive and symptomatic, and then all her symptoms disappeared. She felt fine afterwards, has had 8 sequential positive PCR tests over a span of 4 months in a young, healthy person, which is affecting her return to work, it's affecting her social situation, etc. And nobody knows what this means. I mean, yes, it's probably just picking up viral particles that are not alive and not infectious, but nobody knows at this point because you'd have to do viral culture on all these people, which is not being done. So follow-up PCR tests, probably not very indicative of what's going on and not very helpful. So overall, after a COVID-19 infection, what role for diagnostics? Well, routine microbiology tests are very important to detect secondary and healthcare-associated infections. Molecular tests for contact tracing and diagnosis of contacts after you see that first person. Serology for epidemiology and to make a late diagnosis in individuals who never had access to a test when they were sick or could not get a test. Diagnostic tests for vaccine trial recruitment. Vaccine trials are recruiting patients who are seronegative in order to try and look at naive patients. And you need diagnostic tests to recruit the right patients into these. And also targeted serology and viral neutralization tests after the vaccine to assess the effectiveness and to answer those questions about longevity and whether vaccines are giving protection and for how long, questions that we just don't know today. To be defined are diagnostic tests to facilitate a back-to-work strategy. Should we use serology? Should we use molecular tests to help a back-to-work strategy of who should go back on site, who should continue to work from home, who has at-risk contacts in their family that they want to avoid, and so it determines whether they will be working on site or not on site, et cetera. These kinds of decisions, probably useful in selected cases, but it's not really known whether or not, as a general policy, they can be useful and helpful. And with that, in summary, I think that you've seen that diagnostic tests are pivotal in COVID-19. Diagnostic tests have been thrown into the forefront in this pandemic because of their utility and their value in almost all situations. An example of how bioMérieux is extremely active in this in all aspects of COVID-19 patient diagnosis, prognosis, secondary infections, AKI, whether it's post-COVID epidemiology, et cetera, and the tests that really cover the broad range of patients, COVID-19 patients, and regardless of what stage they're at and where they are in their illness or even in their contact. And with that, I will thank you for your attention and again remind you that diagnostics really is power, especially in this pandemic, and to thank you for your attention.
For joining, and I hope that the presentation was what you expected and had the content, very, very broad content, obviously, because of the topic that we chose. But we tried to cover the highlights of diagnostics related to COVID. We'll go to the questions and answers now. If you have any questions, please don't hesitate to put them into the chat that's available for you, and I'll get to them one by one. So the first question that we had was, does serology from bioMérieux, the VIDAS serology, IgM and IgG against SARS-CoV-2, is it directed against the receptor binding domain or RBD? And the answer is yes, that is the target of the serology for the VIDAS assays. They are both directed against RBD. And as I mentioned during the presentation, the measurement of antibodies against RBD seems to be more correlated with actual protection from virus and reinfection. So these are all obviously all preliminary data, but we have done internal correlations between our serology and viral neutralization in viral neutralization studies, showing that there's over 70% correlation between high titers of VIDAS positive serology, IgG or IgM, against the RBD domain and virus neutralization. Again, this is suggestive that antibodies against RBD are a good way of measuring whether there is protection, although the entire answer is not known. Some other serology, which is directed against the nucleoprotein or the N protein, seems to be less correlated, but again, data still coming in. Again, I would caution you about serology timing. Serology timing is very important. Most of the serologies have an extremely low 30–40% sensitivity in the first 4 or 5 days, reaching much higher sensitivities after 6 days. The VIDAS serology, for instance, after 6 days is about 85% sensitive to picking up cases, and after 10 days, it's almost 100%. The next question has to do with this aspect of overtreatment with antibiotics and whether there actually is a danger of increasing antimicrobial resistance or AMR rates globally because of the COVID pandemic. Obviously, we will not be able to see the impact of the COVID pandemic on AMR rates until several months have gone by. However, there are some alarming signals among some countries where the overuse of antibiotics, especially, well, for hospitalized patients most especially, coming in on the fear that they would have another infection at the time, another co-infection, that antibiotics are given in very high rates, and in those countries expected that there will be an increase in AMR afterwards. I would just remind everybody who's on the line today that AMR has been a global problem preceding the COVID pandemic. Continues to be a problem in countries. It is here during the COVID pandemic, and it will exist after the COVID pandemic. AMR continues to be one of the biggest global crises in healthcare, especially in some emerging countries where resistance rates of hospitalizations can be over 80–85%, especially in the intensive care units. And in some patients, they have pan-resistant organisms that are unable to be treated by any antibiotics, making microbiology tests extremely important in those patients. So we don't really know the answer. We highly suspect and fear that AMR will be much greater and will continue, obviously continue, but the amplitude or the extent will be greater after the pandemic, but we have yet to see that. Another question came in about can serology distinguish between SARS-CoV-2 and other coronaviruses? How specific are the antibodies? And the answer is for all of the tests that have gone through regulatory agencies, we have to show specificity. In other words, we have to show that there is no cross-reactivity with other pathogens, especially closely related pathogens like other coronaviruses. And so I can certainly say that for the VIDAS serology, we've done extensive specificity testing showing that it is 100% specific, and that includes against other coronaviruses in the same family, but not SARS-CoV-2. For other serologies, you have to check the product information and see how much testing is done. Tests that are available on the market that have not gone through the same regulatory approval process may not have done the same type of specificity testing. We have to do quite extensive specificity testing, for instance, to get an emergency use authorization, an EUA from the FDA. Same thing with CE marking. Other regulatory agencies are a little less stringent, or they have different requirements, and you have to check into the data. So the answer is yes, that the serologies like VIDAS are highly specific and will not give you a false positive result from another coronavirus test. Do we have any other questions? I think some of the questions, okay, why would you use a syndromic panel like the BioFire panel versus a COVID-19 test? So I got into that briefly, but it comes down to the question, what additional information, important clinical information, do you get from a syndromic panel that you can't get from a single COVID-19 test? And this is important because it's been important up to now with COVID circulating, but it is certainly important as the winter season is coming in the Northern Hemisphere and other viruses are circulating. As patients start to come in with typical respiratory symptoms, and we will not be able to differentiate between COVID-19 and other respiratory infections, it is going to become more and more important to differentiate who has what. Why? Well, obviously for influenza, moderate or severe influenza, there are treatments available, and you have to know that that's what the patient has before you give them the treatment. That is optimal. For other viruses such as RSV, they can lead to significant healthcare associated transmission or nosocomial outbreaks, especially in children, especially in immunocompromised, and RSV infections can be quite lethal, and there are some treatments available for certain patient types. So knowing that an infection is RSV is important, knowing an infection is influenza A or B is important. Obviously, knowing if an infection is COVID-19 is important for infection control and for epidemiologic reasons and contact tracing. The other viruses also have different, some people say, well, there's no treatment for some of these viruses, so why would I need to know about them? Well, you need to know about them for infection control reasons. Mixing patients, for instance, with RSV and metapneumovirus or paraflu, leads to hospital outbreaks, and we've already seen that. Good infection control measures require knowing what the patient has. And also, there's a lot to be said for knowing the diagnosis in terms of reassurance for the physician and for the patient as well. So knowing that a patient has metapneumovirus or coronavirus or rhinovirus rather than SARS-CoV-2 or rather than influenza A or B is quite reassuring. Those patients generally, if they're immunocompetent, can be sent home with just supportive care, and that leads to reduced anxiety, a lot of reassurance by the patient, or if it's a child, by the patient's parents, less return to hospital, less patient visits, and more satisfaction with the diagnosis when you know exactly what's going on, instead of, well, it's not COVID-19, but we don't know what it is, so go home and come back if it gets worse. So we obviously believe that the syndromic approach gives a lot of information which is clinically actionable and highly valuable, leading to that high medical value that we're looking for. And as I said, there are clear that some indications, some situations, a single COVID-19 test is certainly appropriate. But in general, as the winter comes, there will be more and more requirement to know which virus the patient has in order to offer appropriate infection control, etc. So another question here is, are we going to see less or fewer of the other viruses because of social distancing and homework, etc.? And in relation to COVID-19 as well, the proportion in the coming winter. There is no question that we have already seen decreases versus the usual amount of circulating virus for this time of year. How do we know that? Well, there are different surveillance systems that are in place in various countries, but also we have a software system, and I showed you during one of the slides from our connected BioFire machines called Trend, that gives real-time data on circulating viruses from diagnostic tests. And that trend data, as well as some surveillance systems, is showing us that the normal upswing of general respiratory viruses at this time of the year is slower and lower. Meaning that, yes, social distancing and wearing of masks and the use of alcohol, hand rinse, good hand washing, avoiding group gatherings, and all of the measures that are being put into place to restrict COVID-19 also seem to be having an impact on reducing other respiratory infections as well. So this is good news, but it also means that as the winter comes, we will be less and less able to differentiate who has what and which virus is causing the patient's symptoms. We don't know the relative proportion of each of the different viruses under social distancing rules and under the new norm, shall we say, where people avoid gatherings and wash their hands and use alcohol, hand rinse, et cetera, et cetera. So an interesting question, and I don't think we'll know until the winter season is over how this plays out in terms of the balance between COVID, the other viruses, and social distancing. Any other questions? There have been some questions about antigen testing. Okay, there have been some questions about antigen testing, and they're easy, they're fast. Why don't we have more of these tests available? And again, I would just caution you to look at the tests that have been approved, certainly in the US. They've been approved for symptomatic patients, not for asymptomatic patients, because of their general lower sensitivity. Again, they've all been approved only for nasal or nasopharyngeal swabs, and they've not been validated for saliva or other specimens. Yes, they are rapid, they are easy to use. They are relatively inexpensive, and it's not clear the role that they will have in trying to control COVID as we move forward. But it certainly adds to our diagnostic armamentarium against COVID-19. So it allows labs, hospitals, clinicians to now start choosing based on the situation. Would I have, do I need an antigen test? Or should I go for a PCR test? How many days has the person been ill? Can I maybe do a serology test? When are they turning up, et cetera? So I think that, we're lucky that we have so many different types of diagnostic tests for COVID-19. It does get confusing, and clinicians really have to choose properly for the right situation. And that gets back to my original answer, which is what's the best test? The best test, it all depends on the situation. So you have to look at the situation properly and decide on which test is best. Another question that we have here is, why does it take so long to get results? PCR tests only take hours. In some case, like the BioFire test, it's only 45 minutes. Why can I not get a result of a test for days sometimes? And I would tell you that that's a common complaint in many countries, and it has to do with the system that's in place, the lab systems that are in place, and not the test itself. Many of our tests take 45 minutes, an hour, up to 3-4 hours for batch tests. And there's no reason that the result shouldn't be given clinician or the patient within several hours or even the same day. But the pre-analytic and post-analytic complexity of the healthcare systems in many of these countries and cities and regions makes it that there has to be transport of the specimen to a central lab or to the lab where it's being done. There has to be the test that's being done in batches. They're overwhelmed, so often you don't make it into the next batch. You have to wait for a subsequent batch. And then the results come out. Nobody's around to verify the results, so they have to be verified the following day. And then they get transmitted in an inefficient way in many situations by phone calls or by paper or by faxing in some countries still, not digitally and very efficiently. And so all this adds to long delays in getting results, which actually have nothing to do with the test. So we've worked very hard, and bioMérieux included, bioMérieux, BioFire, in producing tests that are very quick and efficient. Unfortunately, the healthcare systems and the lab systems in many countries, cities, are such that the results take much too long based on the systems that are put into place and have not been updated for COVID, and it has nothing to do with the test. The last question that I have here is why patients under antibiotics? Yes, so why are there so many patients on antibiotics? We now have multiplex tests that can tell what's going on. So why are so many patients getting antibiotics? And you know, COVID is no different than any other infectious disease. Many physicians believe that patients could be co-infected when they come in, and so they want them on antibiotics until they're proven to only have COVID. Some of these patients do come in, and as I showed you, with co-infections, but it's a small percentage. Other patients come in late and they've already got a secondary infection when they come in, and so there's a fear. And there's a general fear that the patient looks septic and they look ill, and if I don't give them antibiotics, they will die through negligence, and I have to, you know, cover them with everything I can, and that includes broad spectrum antibiotics, which unfortunately is an approach that's not evidence-based and leads to a lot of overuse and inappropriate use of antibiotics, as well as generation of antimicrobial resistance, or AMR. We obviously prefer, as a diagnostic company, that people use diagnostics appropriately, and then, you know, based on those results, to give or not to give antibiotics, and to choose the right antibiotic based on the results, and to just give empiric broad spectrum antibiotics for days, sometimes in these patients in the ICU for weeks, without any good evidence, is not good practice, and leads to widespread antibiotic resistance, as well as side effects from the antibiotics in the individual patient, like Clostridium difficile, overgrowth of yeast, allergic reactions, et cetera, et cetera. So obviously we prefer that diagnostics be used appropriately and target those antibiotics rather than just giving everybody, you know, blanket empiric antibiotics. Last question here is a little bit controversial, is why don't guidelines recommend serology tests to check for immunity? And I think we're moving towards that. We're moving towards serology tests, which will be recommended to assess immunity for specific populations. But right now, as enough data for public health people to make large, wide sweeping national guidelines. I think the data will come and that people will be moving in that direction. But right now, the data isn't strong enough for public health recommendations and national guidelines to say you must use serology to determine immunity and back to work protocols or back to school protocols. But I think as more data comes in, as I said, this will be the tendency. And we just need some brave countries to be able to do this first and to see how it works. A lot of our policies in COVID is creating new ways of handling it and then seeing if they work. And I think this is one of them. I think serology will be very useful in the future. Are there any other questions? Nope, I don't see any more questions. So the last few seconds remaining, I'd like to thank you all for your attention. And I hope that this has been instructional and a lot of information coming, an avalanche of information on diagnostics for COVID-19. Please be aware, read carefully, and thank you for joining us today.